It's now my pleasure to introduce again to the group Dr. Joseph. Tell me, sir, what's gone on these last 2 weeks and what can you share with us?
Well, I've picked a couple of topics to discuss today, mostly based on the questions that I'm getting frequently. I will, as usual, share the screen. The things we're going to discuss today are two common questions. Is it safe to fly? And then the term twindemic that's going to be coming up in a few months, and that is when COVID and influenza are both circulating in our community. Then maybe a couple of quick topics at the end. So, is it safe to fly? As always, when we use the term, is it safe, followed by anything, there's two major considerations. That is, what is the risk of getting an infection, COVID, and what are the consequences if one does get infected? Now, the risk always is determined by the background rate, and that was addressed a little bit earlier by Supervisor Anderson in our community, but it has to do with the background rate where you're flying from and to. That is the number of new cases. If we are talking about flying from a hot spot in the United States, the risk is going to be much greater that there would be someone on the plane who has an active infection. If we're talking about areas of the country where the background rate or the number of new cases per 100,000 is low, then the risk is going to be much less that there will be an infected person on the plane. Closeness to others, remember, as we have said so many times, this by and large is a person-to-person disease. And an airplane is a very confined area. And I'm going to compare that in a little bit about being close to others in your own living room as opposed to being close to others in an airplane, because there are major differences that we're going to have to discuss. But the closeness to another person is also a very important part of the risk. Masks must be worn. I don't know if all airlines require masks, but masks should be worn on every airplane by every person. They not only protect others from an infected person, but they also protect you from getting it. The major effect of a mask is to trap the virus from a person who is breathing the virus out. That is, the major effect of a mask is to trap a virus from a person who is infected. But there are also benefits to protect those of us who are not infected. By wearing a good mask, it reduces the likelihood of getting the infection. And airplane air handling is a very big topic. We're going to address that a little bit. So that's the risk. What's the risk of getting an infection on a plane? And then the consequences. If an individual gets an infection, what are the consequences to that person based on their age, medical condition, risk factors for a complicated disease as opposed to an uncomplicated disease? Also under the consequence list is, if I get infected, who might I transmit that to? That is, there someone in my family or my close contact who is immunosuppressed, who is taking medications that affect their immune system, or do they have risks of complicated disease? And then the last component of the consequence is, if I were to be infected, what is the disability to me? If I'm the provider for my household and I can't work, that's very important. On the other hand, if I'm not a provider, would the disability, that is the 2 weeks that I can't work, the 2 weeks that I have to be on home isolation, how will that affect? So this is for an individual. Everyone needs to look at this with their own background, their own social situation. What is the risk? What is the consequence? Now, modern airplane handling is absolutely amazing. When smokers were permitted on airlines, they made major changes to the air handling system in the passenger compartment of the plane. The passenger compartment, by the way, has a completely different air handling system from the cockpit, and the cockpit is even better. But in the passenger component, there is an air exchange every 3 minutes. That's 20 exchanges per hour. That actually is more than what we have in a modern operating room in a hospital, where air exchanges are a very important part of protecting the individual having surgery. So this is fantastic. That is 20 exchanges per hour. And not only is it the number of exchanges, but air is passed through a HEPA filter. That's a high efficiency particulate air filter system. And that will capture most of the COVID viruses. So modern airplane handling is good. So what I've shown on the right is a typical seat map of a 737, which is a very common plane that one might take. And I have the individual there in row 9C as me. If I am sitting in row 9C, the risk to me is really the people around me, not the people in the front, not the people in the back, but the people that are in the row in front, the row behind, and next to me. That really is the closeness. When I talked about what is the risk of flying, it's the closeness of the people around me. I won't sit in 9C unless everybody in that circle is wearing a mask. And I won't sit in 9C if someone in that circle is coughing. That is how we protect ourselves. So is it safe to fly? You can see that it's pointing that direction, that with some common sense activities, it can be safe. So with modeling then, now this is for United States modeling, we actually have come up with some numbers of what is the likelihood of getting COVID on an airplane with the current background rate. And to use a background rate, we had to use the whole United States. It will be different for different areas based on the incidence or the number of new cases or the likelihood of somebody around me in 9C might be infected. But this is how it goes. If we figure a 2-hour domestic flight on a 737 and everybody is wearing a mask, the risk of getting COVID is 1 in 4,300 if you're sitting next to another person. Not another infected person, because we don't know if that person sitting next to me is infected. But the risk is 1 in 4,300. And if there's an empty seat between, and I think I got a flash this morning from one of the commercial airlines that they are still keeping the middle seats open, that the risk is much less. It's 1 in 7,700. So this is where the modeling comes out. It means that the risk is not zero. We are in a pandemic. There's no such thing as a zero risk, and the term safe really is subjective. But these are the modeling numbers that are out there. So with these numbers and what we've talked about at air handling, these are some common sense recommendations that I would suggest that you follow when they're possible. Longer flights have greater risks. If you have to fly internationally, if you have to fly cross country, then you have to do it. But remember, on longer flights, there will be people taking their masks off. There will be people eating and drinking. There will be close contact as people pass each other in the aisleway of the airplane. And there will be people using the bathroom, which represents a high touch area. So remember, high touch areas are areas where if I sneeze into my hand and I'm infected and I touch the bathroom door, that's infectious. So longer flights have greater risk. We have to accept it if it's mandatory that we take a longer flight. If you can, don't eat or drink on a short flight. Keep your mask on. Most of us can go a couple of hours without eating or drinking. Keep that mask on because it protects you and you want others to do the same. Carry something with you to disinfect high touch points. Now, many airlines are disinfecting between flights, but you want to disinfect a high touch point. You don't need to disinfect the seat because that's going to be where your butt is. You don't need to disinfect the back of the seat in front of you, but perhaps the armrest. You don't know if the person before you was infectious, sneezed, or coughed into his or her hand and touched that area. So disinfect high touch points, and certainly if you have to go to a bathroom. Common sense is to carry hand sanitizer. And remember, the reason you sanitize your hands is because you don't want this virus on your hands when you touch your face. And you will touch your face. I promise you, we all try not to, but you will. So hand sanitizer is important. Never take off that mask for the reasons we've discussed. I won't go around anyone who is not wearing a mask. I love airlines who make it mandatory. I know there's been some problems of insisting on wearing masks, but I favor the airlines making it mandatory. And then distance yourself from others. Boarding, sitting, offloading, common sense. What all of us used to do on an airplane is when the plane landed and the bell went off, we all stood up and we were all within 5 or 6 inches of each other. That is something that should not be done during this pandemic. Now, there's a comment that the window seat is probably better than the aisle. It has not been proven. It's a common sense thing. There's better air circulation near the window seat than the aisle, but probably more importantly, there's not people walking by you if they have to go to the bathroom or if they have to go up front. So these are sort of the common sense recommendations. We're seeing the air travel come back. These are things I think you should consider when possible if you have to fly. And the better answer, of course, is don't fly if you don't have to. Now, the next topic, the twindemic. We have an upcoming challenge that we have never seen in my lifetime in many decades of infectious diseases. COVID will be present when influenza hits. We're not going to have a treatment. We're not going to have a vaccine that is available when influenza hits us in California. So let's talk about some differences between the two so that you understand how we have to address this and how our level of awareness is going to need to increase when influenza is in our communities. Influenza is a seasonal virus infection. So far, COVID is not. Predictions that COVID was going to be seasonal have not yet panned out. So we should consider that COVID will be around at a continuing basis until we either get treatment or a vaccine. Influenza is going to be temporary. There's no reason to think that influenza will be different because of COVID. These are two completely different viruses. They're not related. Infection with one has nothing to do with infection of the other. A vaccine for one will be unrelated to the vaccine for the other. They are just two different infections. They're like a measles infection and chickenpox. They're just different, but they will be in our community at the same time. If one gets influenza or one gets COVID, they are not necessarily more susceptible to the one they don't have, and immunity from one does not infer immunity to the other. If one has recently had a COVID infection, it is likely that they are immune to COVID, but that has nothing to do with immunity to flu. If one gets a flu shot and has a very successful high titer or a good response to the flu vaccine, that has nothing to do with immunity to COVID. Two different viruses. Now, Supervisor Anderson said this. This is tough. It's very difficult to distinguish these two viral infections by symptoms. Yet it's critically important to know which one a person has. So if we move into December and January, where it's going to be colder, it's going to be raining, we're going to be indoors more frequently, the symptoms will be the same. But if a person gets sick with a fever and a cough, it's critically important to know whether it is influenza or COVID, because we manage them completely different. The infectivity or the threat to household members is completely different. And what we advise individuals to do regarding self-isolation, quarantine is also completely different. So the bottom line is there. This is how we have to address this in our community and around the country and around the world. We need quick tests. If someone has symptoms that could be either, we need to have a test with quick results that will tell us if an individual has COVID, if an individual has influenza or neither. And we will be there. I'm going to give you a voice of confidence that that is a #1 goal of the United States Public Health Service. The testing will be available. We have it now. We can test for influenza in 15 minutes. We can test for COVID in 15 minutes. Currently, those quick tests, the good quick tests, are deployed to high-risk areas. They're being deployed to nursing homes. They're being deployed to hospital emergency rooms. They will be used by school nurses. They're going to be in special areas, but not by December. They will be available. And that is how we're going to address this twindemic. So I'm going to say this now, and probably it'll come up again in more of these meetings. If an individual has symptoms in the middle of the COVID influenza time, when they're both there, and it's going to be around December, get tested. You've got to know. You can't do what we did last year. I got the flu, I'm going to stay in bed for a week. That won't work this year. This is a major change. Testing to find out which virus one has is critical, both to protect your family, your household, and for your own management. So many questions come up about influenza vaccine. I am a strong proponent of the influenza vaccine, but let's talk a little bit about some of the problems with the influenza vaccine, just so we can keep it in perspective. Production is now done. We're not expecting a shortage of influenza vaccine, but remember, production started last year. Planning for production started last fall before the pandemic. So there are about 200 million doses available in the United States, and that in the past has always been enough. But it's still all we have. Now we have about 300 or a little over 300 million people in the United States. If there is a rush on getting influenza vaccine, we could have a problem. If influenza vaccine becomes more popular because of the pandemic, we could have a problem, because this planning was done before the pandemic, before COVID hit us. So we have 200 million doses. What this means is, when it's time to get a vaccine in California, and I'm going to address that, go get it. Don't wait. Don't wait to see what's going on, because we don't want to run out of vaccine. Now, in 2020, so just so you understand how flu vaccine works and why it isn't a perfect vaccine. The vaccine for 2020 is based on what was present in 2019. We're always a year behind. We hope that we hit the target. This has been the model for decades. We don't have anything better. We can't predict what flu is going to be present in 2020, and we still don't know. We can't look at what's going on in Asia, what's going on in the Middle East, and predict what's going to happen in the United States. So we make our vaccine based on the strains that are present last year, and we're going to do the same thing this year. We will be monitoring influenza this year, and that will determine how we make the vaccine for 2021. Therefore, it's not perfect, because we never hit the target right in the bullseye. We get some of it, some we miss. This is a quadrivalent vaccine this year, meaning there's 4 different strains in the influenza vaccine, 2 influenza A to influenza B. And historically, because we don't hit the bullseye, it's about 40% effective, not in preventing flu. It's 100% effective, or 90-some% effective in making antibodies, but we're making antibodies to strains that are not circulating. So historically, it's about 40% effective in preventing the virus that is circulating that year. So when flu hits us around December, we can assume that unless there's something unusual, we have about a 40% chance of being protected if we get a flu shot. So it's not perfect, but doggone it, it's a lot better than not getting a flu shot. So 40 for a vaccine that is unbelievably safe, to protect yourself or to have a good shot at protecting yourself, it's well worth it. Now, we have 11 different products that are going to be available, and your doctor will know that there are special formulas for persons over 65, those who are pregnant, those who are allergic to vaccine components, those who have allergy to eggs, those who have allergy to neomycin. So there is a flu shot for everyone, and your healthcare provider will know which one for you. And the recommendation hasn't changed this year. Everyone over 6 months old should get a flu shot. I'm aware of all of the controversy. You can see pretty clearly which side I'm on. Everyone over 6 months. Now, the last line is the one that I want to address next. This vaccine is not only 40% effective, it's not ideal, but it doesn't last very long. It only lasts about 4 to 5 months, which means if you get a flu shot in August, you're not going to be protected when we have our highest flu in the community. So we discourage getting a flu shot too early. And the next slide is going to show you what happens in California and how it compares to other places in the country. And that's here. What we're showing here is the line on the left. It represents 2018 and 2019, that we get flu in California starting in mid to late December, and it lasts to March. And what you're seeing on the right, if we take a look at that, you can see that that's not true in other parts of the country. California there is a light yellow, which means that's very low flu activity in the 3rd week of December of last year. But the red, look what's going on in the Southeast and in Texas and even in the Northwest. So the best way to determine when you get your flu shot is to follow the paper, follow the news, be prepared to get a shot as soon as influenza hits California. Typically, I say late October, November is a great time because that will cover us all the way through March. And then the last thing to say is that COVID and flu are different. On the left, you can see the mortality rate of influenza is very low for those over 65. But almost 20 times higher for COVID. COVID is a virus that is much worse. And anecdotally, I think I love this slide, the one on the right. Look what happened in San Diego. When COVID hit, it frightened us so much. Everybody was wearing masks and social distancing, and that also protects against the flu. So the peak time was January in San Diego, and when social distancing and masking started to become popular, influenza fell to almost zero. So perhaps we won't have a bad influenza this year because we still will be following the guidelines of the Public Health Service for social distancing and masking. And with that, I think I'll stop right here. But if there's any questions, I'll try to address them. Mr. Mayor, again, thank you so much for giving me the time. It's always a pleasure.
Thank you, Dr. Joseph. That was absolutely fascinating, especially for those who must travel on planes. It was reassuring to hear the statistics and the facts. I appreciate that. And your comment about how the flu season collapsed last year once people began wearing masks and social distancing, which reinforces the point that every year going forward, we should wash our hands and be mindful of that. Would really help. But thank you. One quick question before we go to all the questions with Steve. Some folks, because the flu shot only lasts a certain period of time, they're thinking about getting it twice, once now and once in January. Does that make sense? And can you do it twice?
Yes, you can. So there's no side effect of getting the flu shot twice. So those who have to travel to areas where there's influenza right now, so if their business travels to Asia, or if they have to travel to the Northeast in October, and perhaps flu will be hot, it's very reasonable to get 2 shots in one season. For when I was doing a lot of traveling and a lot of lecturing, I was in flu areas, and typically I got a flu shot on Labor Day and New Year's Eve. That was my mantra. Very safe to get it twice if it's indicated for a particular person.
But we don't
And
want
I
to,
will caution you.
but we don't want to encourage
My
that
only
because we
caution
have,
about saying this is that insurance companies may not cover it twice.
right. Nor can everybody do it because you're limited to 200 million total doses. And so we want to make sure that you
Correct.
only do it if you're
Yeah,
required.
I'm
Good.
not making a global recommendation.
Thank you. I wanted to make that point.
For Dr. Joseph, there was a question about, we have a focus a lot on the number of cases and deaths. What do we know about long-term or permanent health effects from COVID-19? And you may have answered this many 10 mayor's breakfasts back, but if you could address that, that would be great.
Well, if I said the same thing then as I'm going to say now, it means that I've not been keeping up with it. This disease is a rocket ship, and it's changing every day. A quick answer is every week we are learning that the sickest people are having the longest symptoms after recovery. So being sick or not feeling well for 2 to 3 months now is common. That's the fatigue. More importantly, we are now seeing some individuals developing permanent damage. At least we think it's permanent. Remember, we're only into this for 9 months, particularly of the heart and of the brain. So the sickest people who are hospitalized are now showing evidence that there is heart dysfunction long after the disease has resolved and some neurologic dysfunction. What I can't tell you is that in 6 months, will that be gone, or does this represent permanent damage? But every week there's more information as we get better in diagnostics that this infection is really a bad actor. The stuff that I can get through it and get over it is not appropriate thinking anymore.
Question for Dr. Joseph. Somebody wrote that even with university precautions in place, testing, single dorm room occupancy, et cetera, would you recommend sending a college student to live in the dorms?
Let's go back to the quick answer. It's risk versus consequence. The risk is based on the prevalence at that college campus. And as we have discussed before, some college campuses are screening dormitories by wastewater checking. Some are doing frequent testing of all students. And all of that changes the individual circumstance. And then the consequences, well, definitely not if the college student has an underlying immune problem. But it's such an individual decision that I think the better answer here is to say it really should be evaluated personally. In general, crowds are bad, but there are definitely exceptions where some colleges are fantastic. And I think it's the University of Illinois, University of Syracuse has just come up as being fantastic, providing a safe environment.
Mayor, I think we have, we're a little bit over, but we have time possibly for one more.
Sure.
And this is for Dr. Joseph. A recent report from the CDC said that 94% of patients who have died from COVID-19 had comorbidities. Some people are interpreting this to mean that they died of causes other than COVID-19. How is the cause of death determined?
It's really a good question. This is not new to COVID. It's not different with COVID. The cause of death, or the COD, generally has many factors. Let me give you an example. If an individual has a very severe coronary artery disease and gets a bad case of pneumonia, and that pneumonia caused a heart attack and death, well, it's a judgment call. Was it the pneumonia that caused the death, or was it the underlying heart disease? And that's been an issue in clinical medicine for as long as I have been in it. What we have elected to do is teach doctors to say if the COVID was a contributing factor, it should be listed. In other words, if you can say to yourself, but for the COVID infection, this person would not have died when he or she did, then it's COVID. And that's only by convention. But if I get COVID and have severe underlying disease, my chances of death are much greater. If I get COVID and don't have underlying disease, my chances of death are much less. But that's how it's addressed today.
Great. Now I'm going to reserve the prerogative of asking a quick question about upcoming Halloween to Dr. Joseph. Two things. Some people have talked about getting these long PVC pipes that are like 6 inches diameter. and dropping candy in one side and kids get it at the other end. So they have the social distancing. So the two questions would be, is that okay? And more importantly, if kids collect bags of candy, can they wait 24 hours and is it safe? Parents want to know this stuff, and
Yeah.
grandparents.
Well, I think we've gone, at least in my lifetime, we've gone from accepting unwrapped food products during Halloween. So candy should be wrapped. And the answer is candy, the wrappers of candy is an extremely unlikely way to get COVID. So yes, the candy is safe. I haven't heard about the long PVC pipe, but it's not the candy that's dangerous, at least for COVID. I'll stay away from anything else that can. It's not the candy that's dangerous for COVID. It's the face-to-face contact. So another reason to wear a Halloween mask under your mask.
And keep that social distancing.
That it's a person-to-person disease, not a candy-to-person disease.